going to move from the eyes to the brain, and our friend Dr. Gupta has joined us. Dr. Gupta comes from the Cleveland Clinic, and these are one of our newest clinical care networks. And we're very excited to have you here today, Dr. Gupta. If you want to go ahead and share your screen and take it away.
Okay, well, thank you so much. I actually have nothing to share in terms of
Oh,
presentation.
that's right.
I thought about this and I said, what is there to share with you all? You live with it, right? You have your own experience, the journey of whosoever you're taking care of. I don't have to show you slides. You already know what it is, how complex this is, and how many different confusing opinions you get every time you see someone. Or the doctor says, well, what do you want to do? So I thought I will just use my experience, use my knowledge without actually giving you a chalkboard presentation or anything. There's so much stuff on the internet. You probably have attended so many presentations. And what I can do for you is share some of my experiences, giving you some key things I think that probably would be the foundation of having a child or an adult or a patient with Sturge-Weber, and then really open myself to your question to really learn from you what you face and then give you my tips that come from my experience dealing with this disease. Just to share a few points before I take question, I really think that this is a unique disease. It's rare. That's why most physicians have little to no experience and they try to handle this condition as if it's any other type of epilepsy, and that's probably not the best way to handle this. So therefore, it's very important to really find someone that knows this disease. The second thing I've seen is it's very complex condition. Even though on surface it looks like the child is doing fine, the patient is doing fine, it can silently continue to smolder before you hit big complications. The third thing I've seen with this condition is no two children have the same journey. The two children will begin the same way, but they will end up in a very different place. And that's all very important because all you're trying to do is bend their trajectory to a better side as best as you can. And I also think that this is one condition where epilepsy is very important. It's probably the defining symptom or sign of their future. And therefore, taking care of the brain very early on and taking it very seriously is very important. And lastly, is that fortunately in this day and age, we have so many different tools, imaging, medication, surgery. And I would say it's probably rare now, or probably much, much less frequent that there is a Sturge-Weber patient that we just cannot stabilize. I think that era is probably behind us when we just couldn't do for some patients anything. But now I think with combination of all this, we can provide, a decent quality of life for most of our patients. And for majority, they live very well. Okay. That's what I have seen in my practice. But then I'll stop here and just begin to have discussion with you folks.
Dr. Gupta, it looks like we have a question already in the chat. And as a neurologist, do you advise patients on Keppra for regular blood checks to follow the leukocytes, and oh boy, the eosinophils?
Yeah. So
There you go.
I would say it's not a bad idea in this condition to do blood checks, but the more important blood check would be to check the level of Keppra in the blood rather than worrying about leukocyte and eosinophils. Keppra is rarely a cause of any issues with the blood uh, uh, cells. More importantly, you want to check Keppra to know your child or your family member, where are they with levels, especially looking at their seizure burden, their side effects, and whether their Keppra level is holding up um, as they grow. And that can become very important for some patients where they may be very sensitive to a particular range, which works well for them for seizure control, which works very well for them for side effects. And you can adjust as you need to as they grow.
Okay, gang, don't be shy. This is your opportunity.
Yes, and I think no question is a bad question. That's why we have structured this way. So I'll be happy to answer and share some more insights that I have gained. The next question I see here is, it says, is sleep apnea common in Sturge-Weber patient? I would say, I wouldn't say it's common. I would say that in children, uh, it's actually rare. The times when you will search for sleep apnea in a patient like this would be if you have noted any symptom, for example, loud snoring, some type of sounds during sleep that looks like there's an apnea, or the patient is relatively okay, but has periods when their seizure controls get out of hand. Um, and you can screen for it, but as much as I'm aware, the standard guideline or practice parameter or looking and managing their neurological things, it's not one of the top things we do. We only do it if we suspect based on some parameter, either clinical or EEG or something. Okay, I have another question here. It says, as an infant with only one seizure now, is there a trend as to when seizure become more prevalent or any specific triggers to epileptic seizure as a result of Sturge-Weber syndrome? That's actually a very good question. So generally speaking, in this condition, when it begins in infancy, you should be prepared for perhaps a possibility of a rocky course or a possibility of a disease that may evolve into a more severe condition. It may not, but you have to be vigilant. And the reason I say that is basically when you have seizures in infancy, it's telling you a few things. It's saying to you that the disease is perhaps more epileptogenic or more prone to produce seizure. The disease might be more extensive. The area of calcification or calcium deposit, or the area where there is a malformation of the blood vessel may be extensive. And typically speaking, when these infants have seizure, they tend to be long. So I don't know. Brian and Nicole has asked me this question: how long was the seizure in the infant that they refer to? But seizure tend to be long. If they're not long, they tend to cluster one after the other. So if they have a day with seizure, they can have more than one. If they have a week with seizure, they will have many, or they could have a long seizure. So if you see that, you have to be aggressive with the seizure treatment. You have to be vigilant that more may follow. And what your goal should be to remain ahead of the seizure rather than following and trying to adjust things. That's where I think many not mismanagement, but many sort of preemptive steps can occur. Because if you treat every seizure in this condition with a little bit of more, or a little bit of this, or a little bit of that, it's not the way to go. The way to go is be aggressive, hit them hard, control them, monitor them, and eliminate them to the point that they only occur with infection, maybe a little head trauma, maybe when the child is sick, maybe their shoulder, with whatever intervention can you, rather than dealing with lots of these seizures and making little adjustments. You want to make big adjustments and deal with less seizures. Hope it makes sense. And that all comes to the, of course, what you see and what's the skill of the person, the knowledge of the person about this condition that you're working with. Okay. I have seen this many times in my practice. A child goes back to the doctor, seizure, seizure, 5 milligram of this, 2 milligram of this, 25 milligram of this, and it does nothing. And the child keeps seizing and ends up in the emergency room. And it ends up a lot worse when big decisions are made. You want to make these big decisions preemptively. That's what I have learned, rather than just keep doing little things that work nowadays. Because if you do that, you are ahead of the game. I hope it makes sense. That's how I believe in. And that's what my experience is. Probably what's not written in the textbook, but that's what my experience is. Any point, counterpoint to what I said?
Dr. Gupta, can you explain what you meant by with control, but illnesses? Because we get a lot of that at the foundation. We get that question about illnesses and the threshold.
Yeah. So this is one condition where I would say an illness or a fever is a robust trigger for seizures. In fact, if you see majority of the patients with Sturge-Weber, you fix their seizure, they go home and they remain well for few weeks, few months, sometime a whole year. You never hear anything. And then suddenly they have a little fever, little illness, something happened in their life, and a little seizure comes in. You should have a robust plan we call as a rescue plan. What happens if a patient goes into an illness or a fever without a seizure? What should you do? What should you do if the illness and fever occur and a seizure begin to happen? What you should do? These are clear rescue plans that you should have, because again, a seizure during an illness or a fever could be the trigger of the next vicious cycle. You don't control it very well, and they go another day, another week, another month, and they go through this spiral backward, and then you have to pull them out of the well. So you should have a big, good rescue plan that stop them right in their track, and the child recovers, and then you have a short spell with seizures, and the child bounces back very quickly. That's another thing I think my experience tells me, and that's why whenever I see these children, I give them three plans: what to do when they have a fever and illness, but even no seizure; what to do when they have a fever, illness, and a seizure; and what to do if they have fever, illness, and more than one seizure, and your rescue at home is not working.
There is a question here that goes along with this with Dr. Gupta, is that, do you recommend ever adjusting seizure meds if your child is sick? And then I know I've been recommended to have like a bridge medicine. So
that is correct. That's exactly what you do when your child is fever and sick. You have not seen a seizure, but you worry that it's going to happen. You could do a number of things. You begin a bridge medication for 3 nights, 5 nights, hope it would not occur. The best thing that you can do your child during illness is fever is hydration. Hydration, I would say hyperhydration or superhydration, because if there's anything that can help the drainage to this capillary angioma, it is the pressure inside the vessels in your body and the brain. That's the only way you can increase the circulation and prevent the deprivation of oxygen or ischemia that can worsen. Okay. And the third thing you do is you get them sooner to your pediatrician. So the illness, if it needs antibiotics, it needs something else, is taken care of very quickly, and you have a shorter illness course. And then the last thing you do is, if you begin to see seizures or your rescue plan is not working, these are one patients where I would say you should seek emergency room treatment, because what you're trying to do is you're trying to prevent the onslaught of number of seizure or status. So I have patients who have history of these clusters and status that we have a plan of care where after the first seizure, they get admitted, they get fluid boluses, they get IV medications so that they don't have to go through a vicious cycle of seizure after seizure. If there is one condition where one seizure can herald many, this is one of them. I don't know what your lived experience is, but that's something we know can happen. We have seen it and written in the literature.
there's a question about the dehydration. what would you advise to prevent dehydration relating to lower effects of Keppra for the young adult Sturge-Weber person?
So I tell all my patients with Sturge-Weber, there's one thing they have to do on a daily basis, which is hydration, hydration, hydration. This is simple. I'm not asking them to take any electrolyte solution or anything. It's simple hydration. And of course, during summer, more hydration. And I think it's not something that has been studied in a very elaborate manner, but we know that uh, the pathology in Sturge-Weber is such that if you can do anything to promote the drainage of blood across this angioma, you should do that. That's why we put them on aspirin, okay, so that the blood is not as sticky. That's why we say do hydration so that there's enough pressure in their cerebrovascular system or in their blood vessel in their neck and head that keeps pushing the deoxygenated blood out and keep supplying good oxygen and uh, blood supply to the brain. So hydration in Sturge-Weber, in my opinion, is everyday thing and more important in summer, more important in illness, and even more important in fever, which makes them prone to hydration.
Um, Kimberly writes, we're currently weaning our 8-month off phenobarbital. She's also on Keppra and Troneptal. Any advice for this wean?
My advice is that perhaps you've had that discussion with your doctor. If you think that the child is stable, these two medications would be enough to keep your child seizure free. It's very reasonable to wean off phenobarb. It's often the med that get begun, in early life. If somebody goes to hospital, it's the med that has more side effects in terms of development, learning, as well as sedation. My advice is do it slowly. Watch your child very carefully. Measure the levels of other two drugs to make sure that they stay up. And if you see any setbacks, stop there, ask your doctor again, refigure next steps. And that's another thing you have to learn about this disease, which is the plan you make today is not the plan in 3 months or 6 months. Sometime you can make a plan and it sticks for a year and then you have to reboot. So in other words, a close follow-up, a close monitoring is what is essential, especially in those Sturge-Weber patients who develop seizure early in infancy, and who have gone through rocky course. You cannot substitute anything for a very close follow-up of everything: development, seizure, meds, side effects, deficits, everything.
So the next question is about puberty. What signs do we watch for that she is seizing after a left functional hemispherectomy? Would they
Where is the question?
be the same as before surgery, or how often have you seen seizures return after surgery? That's a complex question.
Let me go to the question. Who's asking this question? If you can tell, there's so many here.
Yep, it's a NETS iPad. It begins with
When a child begins
puberty.
puberty, what signs do you watch for that she's seizing after a left functional hemisphere? Seizures in puberty will look like seizure of anybody else. So I would say if your child has had left functional hemispherectomy, um, you should find signs of seizures. Now, it is possible that after hemispherectomy, her seizures would look different, but the two most common type of seizures after hemispherectomy would either be a staring and some stiffening like this, like this. Less commonly, it would be more obvious, which is you have a big seizure and some jerking. But I wouldn't say that there is a differentiation being pubertal or prepubertal. Any child between the ages of um, 5 to 18 who's had hemispherectomy, the seizure will more or less look about the same. Okay. I mean, every child will have a different type of seizure or different look, but that would be in general a motor seizure and a staring seizure. And like I said, they can be different before surgery. They will perhaps hopefully be less intense, maybe shorter, because your child has had surgery and has eliminated most of the abnormal tissue. How often have you seen seizure return after surgery? Well, that's a question which is based on many factors, which I hope your doctor has discovered with you pre-operatively or before surgery. And that often depends it whether your child has one side or two sides Sturge-Weber, whether the resection was smaller or hemispherectomy. In your case, it was hemispherectomy. Were there seizures from the other side? Was there a brain malformation on the other side in terms of vascular? Was the hemispherectomy disconnection complete? So things like that. I would say all in all, if everything came from one side of the brain in Sturge-Weber, it's probably one condition where the results of seizure surgery should be very high, as high as 70-80%, provided your child had everything coming from one side. So, of course, I don't know your child's specific instance, but that's what I would say.
Thank you very much, Dr. Gupta. She did have a total like the whole hemispherectomy. It was totally disconnected. Everything was on one side.
Okay, good.
So,
Good.
and these questions come because we just want to be ahead of the game versus behind it, right?
Absolutely.
So asking questions will
Good.
hopefully help us in the future.
How long has she had
6 years.
6 years after her hemispherectomy?
She had her hemispherectomy at 3 and she's now 9. So it's been a little over 6 years.
No seizures?
No seizures.
See? So that's exactly what my experience is. If you have the right candidate, the success rate is very high. Good. Good to hear.
Thank you.
So Dr. Gupta, I'm gonna, if you don't mind, just skip the surgery questions because Dr. Shahani is gonna talk about that later on.
No problem.
But we do have one about a correlation between Sturge-Weber syndrome and the migraine headaches. What is the recommended treatment for migraines if they were, say, an ocular migraine?
My experience is that this is a complex subject in Sturge-Weber. So there are some patients where their migraine-like headache is periictal. Periictal means it somehow comes along with the seizure, either preceding or during or after. It's mixed in there. Some family will say, I think there was a seizure and then my child threw up and had a bad headache or something like that. The other type of headaches in these patients is they just have a bad migraine or a bad headache. I would say to you that each patient should be evaluated carefully to determine, is this migraine a symptom that's coming along with some seizure, either before, during, or after? In that case, you would treat this migraine as if it was a seizure, along with some more pain medications if you have to, if they are throwing up and if they have a bad headache. If you are convinced there is no seizure and this is pure headache, then this can be treated more like a headache. And typically speaking, the best treatment would be medications like Tylenol, ibuprofen. They do not increase the risk of bleeding or anything. What is controversial, and you can also give some medication under the tongue for nausea or emesis. What is a little bit controversial is, can you go back to some other treatment that are now available, which can constrict the blood vessels of the brain? These medications are often called triptans, like sumatriptan, rizatriptan. There are many, many of them. I don't think there is a jury out there. I tend not to use them because there is a potential that it could potentially, make the blood supply of the brain more compromised if it already is. So I tend not to use them. I tend to restrict myself on pain management, ruling out seizures, and management of symptoms like nausea and vomiting.
So one last question. I know they're having a conversation now, and it's lovely. Actually, there's two here. What other triggers do you feel are triggering some of these seizures? I know we talked about dehydration. I know we talked about illnesses. Are there any other triggers that you would think, Dr. Gupta, that we haven't talked about so far?
I think the other important trigger that I have learned in this condition is, for some reason, I don't know why, but if your child or adult has Sturge-Weber and they happen to have some type of head injury, and it could be a minor head injury, like they hit their head against something, that can trigger a seizure-like episode. So again, this is not written, maybe it's written somewhere, but not studied as best as it should be, but something I have seen more than once. So be aware of that. If your child had a big fall and hit their head, just be more vigilant. That could be another trigger. The other thing to remember in this condition is many times, especially little kids, infants, when they start with seizure, it doesn't look like a seizure. It looks like this. This little finger is like doing like this, like this. And you say, is it a seizure? Not a seizure. You take a child to the emergency room, the doctor will say it's nothing, go home. Then next day it stops and then it becomes a more hand-like thing, like this. And then you go back to the ER, the doctor will say, let's give him some medication, do an EEG, and EEG is nothing. They'll say, go back home. And then it evolves over hours, days to a full-blown episode. So again, if you know this is how your child's seizure begin, you active as this is an impending bad seizure. That is the time to treat, not 3 days later. And we have, again, patients where we put this plan of care. If they have this is a seizure until proven otherwise. That's what I would say about these things.
And now I'm sure, Dr. Gupta, you would agree, right? When we change schedules, we go on vacation, and we do all the wonderful things that we do to live life, it throws us into that other piece of the puzzle. Because I see some of the comments going back and forth, and we get that call a lot too, right?
Absolutely.
You change the season, and then we go on vacation.
Anything that increases the physical activity, level of exhaustion, lack of sleep can throw them up. I totally agree.
Absolutely. Well, Dr. Gupta, I'm going to leave you here. I see my friend Dr. Loeb just joined us. So thank you so very much for joining us today. And I know there's a lot more questions in here that I'm going to be sending to you. If we don't get through to them with Dr. Shahani with the surgery piece, we'll send them to both of you. But we appreciate you more than you know, and thank you.
Thank you, and best of luck to all of you. I know this is a complex chapter in your life, but one that can be managed if you have the right partnership with your doctor, okay? Thank you very much.
Thank you, Dr. Gupta.
Bye.